Dean Altman. I wanted to thank Max and the co-director of the Law Medicine Center, Associate Dean Sharona Hoffman, the Associate Director, Professor Jessica Berg, for organizing this event. I just want to say a few things about the center and about Professor Melman, and then he will make the introduction. The Law Medicine Center was founded in 1953. Oliver Schroeder, after whom this lecture is named, was one of the co-founders. He was then a young law professor, founded it with two nationally renowned physicians. It is the oldest center in the United States for the study of health law. Health law programs have been ranked by not the usual U.S. News thoroughly arbitrary method, but by actually seeking out knowledgeable people who teach in the area, and those people have consistently ranked this health law center in the top 10. Most recently, it's been ranked number 5. Professor Melman succeeded Oliver Schroeder as the director in 1986. Max came here 2 years before that after spending 10 years at Arnold & Porter. He's the author or co-author of 4 books, many articles that really span the fields of legal medicine, bioethics, and health law. As far as him as a faculty member, I would have to say this is sort of a dean's dream faculty member. He's a dedicated and versatile teacher, a nationally renowned scholar, and he's always incredibly busy, but always is willing to do things when asked, and does them extremely well and conscientiously. One of the key ingredients of the Law Medicine Center is the lecture that you're seeing an installment of today, the Schroeder Lecture. It honors individuals who have made significant contributions in the fields of health law policy. The lecture was established in 1986. Gifts from law school alumni, friends, and colleagues of Professor Schroeder in recognition of his dedicated service to the law school. I came here a little more than a year ago, and I did get to meet him briefly. He is really one of the people that I always hear mentioned as truly one of the founding forces of the law school, someone really critical to, I think, the current success of the school. He was a professor, but he also served as acting dean for, I believe, almost 5 years. So I'm going to turn over the program now to Professor Melman, Professor Schroeder's successor as the director. Thank you.
Thank you, Dean Simpson. Thank you. Welcome to the 2007 Schroeder Lecture. As Dean Simpson mentioned, by the terms of the charter of the lectureship, the lecturer is to be selected on the basis of, quote, scholarly distinction and contribution in the arenas of health policy and law. Does this year's lecturer fulfill this requirement? Well, let's see. He is Dean and Saul C. Chaikin Professor of National Health Policy at the Heller School for Social Policy and Management at Brandeis University and served as interim president of the university in 1990 to 1991. He holds a Ph.D. in economics from UCLA. Between 1971 and 1976, he was Deputy Assistant Secretary of Health for Health Planning and Evaluation. He has been a health policy advisor to Presidents Nixon, George W. Bush, and President Clinton. He was a senior member of the Clinton-Gore Health Policy Transition Team. He was the chair of the Prospective Payment Assessment Commission, which advised the government on how to pay for hospital care under Medicare from its inception in 1984 until 1996. He was a member of many other, was a member of many other advisory groups, including the National Bipartisan Commission on the Future of Medicare. He has testified before Congress more than 35 times. He is the health policy advisor to presidential candidate Barack Obama. And in 1988, when Massachusetts Governor Mike Dukakis signed into law a bill making Massachusetts, quote, the first U.S. state to guarantee universal access to health insurance, our Schroeder lecturer was quoted as saying, "It's incredible. I think Massachusetts is going to make a lot of important history." In 2006, Massachusetts once again became the first state to guarantee universal health insurance. How could this have happened? Don't ask. But once again, our Schroeder scholar was consulted for his opinion and was widely quoted as saying that the legislation was, quote, not a typical Massachusetts, Taxachusetts, oh, just crazy liberal plan. And last but not least, he has a Cleveland connection. He delivered his first scholarly paper at a forum here at Western Reserve University in the early 1960s. So I'm sure you would agree with me that he is more than well suited to be our Schroeder Scholar, and I ask you that you join me in welcoming Stuart Altman, who will speak on the U.S. healthcare system in irons. In which direction will it emerge?
Thank you very much, Dean and Professor. Yes, this is a pleasure to come back to now Case Western, and I remember fondly my first, as a young, very young, sort of newly minted Ph.D. to come here, so it's been a pleasure to come back, and I've had the opportunity to come back before. Professor Binstock and I are good friends, colleagues from Brandeis before you stole them away from me, and or us, and so it's a pleasure always to come back. You might find my title a little strange, so let me give you a little more of a history to it. I have a house on a lake up in New Hampshire. And for years, I would sit there and watch these little sailboats go by as I, sipped my martini or like. And I kept saying to myself, I really should learn how to sail. I really should. And I kept sipping my martini and watching them sail. And finally, I got up enough nerve this summer to take lessons. How many sailors we have in the room? Anybody sail? Okay, well, I think you'll appreciate this. And you can explain it to others. So I took up sailing, and, I said, well, where's the engine? How do we go straight? He said, the engine's up there, it's the wind. And I said, well, okay. And he said, well, you got to make sure that there's enough wind in the sail to sort of sail, in the direction you want to go. And I said, well, suppose there isn't. Or suppose the wind is blowing in one direction, you want to go in the other. He said, you have to tack, which means you have to sort of turn into the wind, get the thing moving in the other direction, and then eventually it pulls you along, and then you got to go back and forth. And so I'm beginning to get this thing. I'm beginning to really understand how to sail. This is a lot of fun. and sailing and stuff like that. And then, after, I don't know, first, second, third lesson, he said, there's an issue I really need to tell you about. I said, well, what's that? He said, we've been tacking back and forth, and you've been doing fine. He said, but the one thing you don't want to have happen is that if you're halfway through going through this thing and there's not enough wind, all of a sudden, your boat will start going in all kind of strange directions. Technically, you are in irons. And I said, well, what does that mean? He said, it doesn't mean something good. He said, the sail will be flapping around, and you could wind up going backwards, sideways, right into the... He said, don't have it happen. Well, as life would have it, of course, it did happen. And sure enough, I wound up going backwards and into the weeds, So I sort of remembered that, came back and started thinking about things I sort of do on a more routine basis, which is healthcare policy and where our system is going. And the more I thought about it, the more it said to me, that's our healthcare system. We have been flapping around, making all kind of moves, making changes, doing all this stuff. And unfortunately, you heard my background. I've been at this for a long time. And at the end of the day, we have the same problems we had when I started, except we're in much worse shape. And so I said, well, this is our healthcare system, and I think we need to sort of deal with it. And of course, the problem, when I first started in '71, for those of you who have your concerns about government, this story is about to sort of come true. I had absolutely no experience in healthcare, and I turned out to become the chief health policy person for the U.S. government in 1971. And and the two issues that hit me, well, it took a little while to sort of find out where the men's room was, the women's room was. I was trying to figure out the difference between Medicare and Medicaid and all these complex things. And then I sort of started to figure out we had a bit of a problem that we were spending a lot of money. And then all of a sudden, now this is like a month after I started in July of 1971. In early August, this good conservative Republican president, Richard Nixon, imposed wage and price controls on this country. The largest, most comprehensive set of controls in healthcare in the country and for all services that we've ever had, except for the wars, I guess. During the Second World War, of course, we did a lot more. Well, I was trained, as you heard, UCLA, which, if you know anything about economics, is like a farm school of the University of Chicago. Believe in markets and, no government and stuff like that. And all of a sudden, we're into this regulatory system, and I get called to the White House. Now, you did not want to get called to the White House during those days. It was the era of Haldeman and Ehrlichman, and people would go to the White House and disappear. It was just not a good thing. So I finally got up enough nerve, and I went to the White House. And I got there, and sitting around the table were all the president's men. Sorry, no women. They're all around there, and Chairman of the Council of Economic Advisors says to me, Dr. Altman, you know how much money we're spending on health care in America? Truth of the matter is, I had learned the day before, because I had a staff person that actually really did understand something about health care. But before I had a chance to say anything, he said, we are spending $75 billion on health care. It amounts to 7.5% of our GDP, and it's going to be your job to make sure that it never reaches 8%. Because if it does, our whole way of life could deteriorate. I'm 31 years old. I don't give a damn about health care. I haven't been in a hospital since I was born. My president wants me to control healthcare costs. I'm going to control healthcare costs. And I'm going to go out there and do the best job the world has ever seen. And this is how successful I've been in my life. And the reality is that healthcare costs have just continued to go up and up. Now, I want to make a distinction. We talk about costs, but I'm really talking about spending. Now, in a technical term, costs are really the cost of a unit, and spending is a combination of the cost of a unit and the number of units. Now, of course, we sort of interchange them, cost, spending. We sort of talk about them interchangeably, because what one person's cost is another person's spending. But the reality is what we're talking about here is per capita spending or expenditures in healthcare. And so we have this ongoing problem. For those of you who have been asleep, we've clearly gone from 7.5%, which I'll show you in a minute, to much higher numbers. And we continue to have these three problems that I put on before, but I won't go back. While we're spending so much money, and we are like 4 or 6 percentage points higher than any other country in the world in terms of our expenditures per capita or per GDP, the average in the other industrialized countries is around 10 to 12%. England's a little less, Germany's a little more. And at the same time, we have 47 million Americans with no health insurance. So we have these twin problems of costs and uninsured, and now we've added a third one, which for someone like myself, who is sort of blindly naive and sort of believe that if you carefully select a very intelligent group of very arrogant people and anoint them as doctors, they will do everything that's right. And so you never think about quality problems. Now all of a sudden we're hearing all these stories about quality problems, errors human, Institute of Medicine, 100,000 people die of medical errors. And so now we have to add a third problem to our list, and probably we've always had it, we just didn't know it. So we have these three problems: rising costs, which we're going to talk about, quality issues, and 47 million Americans with health insurance. And we're flapping in the wind. And it's not clear to me that we're sort of engaged in any meaningful changes in this issue. As you can see from this chart, as I said, I started in 1970, we're 7.5. 2005, we hit 16.5. And who knows where we're going to wind up. I have given up trying to predict. People kept saying, I would have bet big bucks back in the 1970s that we would never see 10% of GDP on healthcare. Impossible. Impossible. So when people come and tell me, we cannot keep going like this, we're going to destroy our system, at one level I say, you're right. At the other level I say, I don't know. I don't know where it's going to stop. And my sense about it is that we're not going to just wake up one morning and it's blown up. Our issue really is the potential for what I would call a meltdown. And when I define a meltdown, will be increasing numbers of Americans that have no health insurance, or even if they have health insurance, can't afford the care that we have the capacity to deliver. How many of you are in the healthcare business in one way or another? You're doctors, administrators, a few of you. Okay, well, you know, I mean, I'm a believer, you know. I sit on hospital boards. I'm very involved with teaching hospitals. And I think generally, in spite of the issues about quality, you know, most people in the healthcare arena, doctors, hospitals, even people, drugs, equipment, are trying to do the right thing. Of course, they want to make a few bucks in the process, but they're trying to do the right thing. So the issue then comes down to, does it really matter? Who cares? Now, there are some, and even in economics, that believe that if you carefully read the Bible, I wouldn't say that I'm the expert on this issue, there is a passage in there which says that the United States is going to continue to grow by 2.5% beyond inflation, and you should not mess around with it. And they point to this chart as saying, you know, a little bit below, a little bit above, but it is God's, excuse of those religious will, that this is it. You know, you mess around with it at your own peril. Okay, well, I mean, and so as a result, they said, well, don't worry about it anymore. And there is some would say they're apologists for our system, and surprisingly enough, they're often at the University of Chicago. But that's the University of Chicago for you. Hasn't changed a bit in 45 years. But I believe that if you really look deeper into these long-term trends, you will see cycles that really are very important. And what it points, and let me just go through them very quickly. First of all, we have the red cycle, which, I mean, I just picked up colors, nothing personal, but that was when we added Medicare and Medicaid to our arsenal, and healthcare spending grew quite rapidly. And then, ironies of ironies, we had the 70s in yellow, when, as I said, not only did we have wage and price controls, but for those of us who grow up in that era, we had all kind of constraints. We introduced certificate of need laws all around the country. We made instant millionaires out of lawyers and consultants, all fighting about these, you know, building new buildings and stuff like that. We created health planning agencies all over the country, and we had thousands of young people trained as health planners going out, trying to figure out how many hospitals, how many mental health centers and stuff like that, and what kind of stuff. We had all kinds of rules about where we can distribute new types of technologies and build new things and like that. And for a while, it actually slowed the rate of growth. So if you look at the slope of that line, it's actually, you know, it's growing, particularly in the latter part, but during that particularly 71 to 76 period, it's fairly flat. And then sort of in 74 or 75, the economic stabilization program ended, and we started to grow. And then we hit the 1980s. Now, Ronald Reagan becomes president. We eliminate health planning because it just turned out to be battles between lawyers against lawyers and so on. So as I said, while it was a make-work activity for a lot of law graduates, it tended to have, at the end of the day, very little impact on controlling costs. And in my state, I had just come to Massachusetts, and I saw the classic example of that. And I'll just give you one example of it. Built into one of the early laws was the creation of the renal program in Medicare. And built into that law was a restriction on the number of transplant centers that any community can have, based on the size of the population. And so the people in Washington, with a kind of narrow view, decided that the Boston area should have 2 transplant centers. You ever been to Boston? So we're going to have 2 transplant centers. Obviously, the first one has to go to the Mass General. After all, they're, you know, kind of special. Well, that's what they say. So they got 1. The next one said, well, the Brigham was then not affiliated with the Mass General. They have to have 1. The Beth Israel, the Jewish-sponsored hospital that had just finally made it into the inner sanctum with the Harvard, they had to have 1. So they decided they were going to have 3 rather than 2. Then we had St. Elizabeth's. St. Elizabeth's, which was the cornerstone of the Catholic hospital system, said the Protestants have one, the Jews have one, the atheists have one, and we want one. At that point, Dukakis put his foot down. He said no. Have you ever been to the legislature in Massachusetts? There were 2 people that aren't Catholic. It's just not something that happened. So all the consultants are fighting in civic and need laws, and it was all wiped out. And St. Elizabeth got one, and then Tufts got one, and Lane Clinic got one. You know, pretty soon you could get one on the street corner. You wanted to have it done, you could just... And that's just one little example of what happened. I'm sure there were examples here in Cleveland as well. So, you know, Katie barred. So then we hit the 80s, and Katie barred the door. I wrote a couple of papers on halfway competitive markets and ineffective regulation, the American healthcare system in the 80s. It was, you could do anything you wanted. You know, as long as there was somebody going to pay the bill. There was no one constraining this. We had no markets. We didn't have fighting among competition, and we didn't have regulation. And you can see the green line, and you can see the trend line. And then we come to the end of the 80s, and lo and behold, American businesses are going crazy, just like today, as you picked up the paper and the strike in General Motors. We had corporate America, particularly the large autos and steel, that were going apoplectic. They were claiming that they were losing market share to European, that they couldn't compete in the international marketplace. They were sneaking into Washington, begging the government to help them. Now, these are all good Midwestern Republicans who, on face value, hated government, but were sneaking in and saying, please help us. And so we had an election in 1990, and Bill Clinton figured this out a little before the other guy, and, you know, he wins the election. And then there, some of you may remember, we had the Economic Summit in Little Rock, all over the world, presidents sitting there listening to all these people pontificate about one problem or another, and they let me go and make a presentation on health care. And then following me was Red Poling, who at that point was the president of Ford Motor Company. And he laid out very clearly that American industry could not continue to function and survive without some really slowdown in healthcare spending and cost to them. And Clinton decided he was going to have this great complicated plan, and some of you may have studied it. I won't go through it. I was in the transition team. Well, I'll tell you a little story. So we're down in Little Rock, and all of a sudden it's clear to me that all the plans that we were working on were gone, and this other guy who I call him Rasputin. We won't talk about his name. He decides that it's going to be this different kind of a plan, and he gets up and he tells the president, because we had told him that in order to have national health insurance, it was going to cost $120 billion. For us, it was not a lot of money. You know, when you're in Washington, what's $120 billion? It was like 10% of spending we were about. And, you know, we were going to cover everybody. We were going to have mental health parity. We were going to have prescription drugs for Medicare. What's $120 billion? I thought the president was going to have an apoplectic effect. He said, $100 billion? And we kept talking. He kept saying, $100 billion? After the third time, we got it. This was not a good number. Not a good number. One little guy who looked just like me when I had been there 20 years before gets up and said, Mr. President, he said, we have an alternative way of doing this. And we can cover everybody, do everything you want, and it will cost you absolutely nothing in terms of new money. The president smiles. Hillary smiles. Everybody was there. Gore was there. Rubin was there. Stephanopoulos was there. And they were all happy. This was going to be the new wave. Now, remember Dr. Strangelove? This arm of mine, I couldn't control it. Shut up. I was in line for a big government job. But up it went. This is a true story. President said, yes, Stuart, what is it? He said, I said, Mr. President, I know what they're talking about. This is going to kill you. This isn't going to work. You're going to be rearranging the whole healthcare system. You're going to be moving everyone around to new delivery systems and stuff like that. Americans are going to rebel. So the president says, well, you know, we'll work it all out. We'll get back to Washington. We'll put everyone together. everything will work out. We walked down there, he puts his arm around me, big Bill with little Stuart. He puts his arm, he said, Stuart, you're a great American, and I was gone. Absolutely gone. I was back to Brandeis so fast, but I'm a tenured full professor, I didn't care. You know, it's just all right. Anyway, the whole thing fails, but we get managed care. And look what happened to managed care. We have that white mark, and they actually did what we asked them to do. They slowed healthcare spending, whether it was done by managing care or managing costs, discounts, stuff like that. For a while, everybody loved them. And then everyone hated them. Patients, providers, the press, the politicians. And so, since around the late 1990s, insurance companies don't manage care anymore. They're still called HMOs, a joke. They don't do anything serious. What they do, you want to go to a specialist? You want to go 2? You want to go to 3? You want 4 MRIs? Okay. You got nothing else to do? You want to have open heart surgery? Fine. But they figured out it was much easier to raise premiums than to fight with the doctors. Our good friend Jack Rowe gets hired at Aetna as a doctor to make nice to the doctors. And he did. And health insurance premiums go through the roof, which I'll show you in a minute. Healthcare insurance company profits are the highest they've ever been. And no one's controlling the store. And look at the growth rate we've seen since the late 1990s. The largest growth rate in the history of this, since 1965, probably in the history. So the question is, we are in trouble. We're in worse shape today than we were before. So the question is, if the U.S. continues to allocate an increasing proportion, what's going to happen? So I'm going to focus on the largest component of our financing system, what I call employment-based insurance. Over 60% of Americans are insured through their job. This, and I don't have time to talk about it, and you probably talk about it, it's a historical accident that has grown up from the Second World War. And you can sit there chapter and verse, and many of you in classes probably have heard it, why this is an awful system. There's problems with it. You know, it reduces labor mobility. It's unfair. The wealthy, higher wage people get a better tax break. I mean, you know, I've done it. The list, but it's America. It's ours. Now, we have 2 forces that want to eliminate employer-based health insurance. Depending on your preference, on the left are people who want a single-payer system. And this employer-based system is mucking it up, because if we get rid of it, then we can have government run the whole thing, which is what they want in the first place. And so they'd be just very happy. Ironically, on the right, people that never talk to each other totally agree with them in terms of the employer. They want to get rid of it, but they want to have individuals buy their own insurance, market forces, having nobody in between the individual and the doctors. The employment-based system. So they are both a bunch of happy campers that these health insurance premiums are going through the roof, and that's the growth rate. And even worse, look at the gap between the rise in health insurance premiums, which is over 90% since 2000, while wages are only going up 20%. This is the General Motors problem. And you can just feel it. You can watch it. There is going to, you just play this one out over time. Health insurance will be $20,000 pretty soon. Now, there are a lot of workers that don't make $20,000, or they make it, so an employer is going to wind up having, even if they pay half of it, they're going to be paying 50% of compensation on health insurance. So, not surprisingly, more and more firms are opting out. So the question is, has the meltdown really already begun? Now, you can look at the statistics in 2 ways. The sky is falling. These are the numbers. We have seen a reduction since 2001 in the percentage of employers that provide health care to their workers. And if you look at that chart, this is catastrophic. Now, of course, there's another way to look at that chart. Same numbers. Of course, now I have a scale from 100 to 0 before I had it. But the point here is, we have seen a serious deterioration. Whether the meltdown is in catastrophic or it's a serious problem, it's real. And as I said, that's why the General Motors issue is so important. So the question is, where is it going? And another unpleasant trend is that we've seen a very major reduction in the number of firms that provide wraparound retiree health care. That's also the General Motors. If you're not in a big, highly unionized company or work for a state and local government, you don't have wraparound coverage. Oh, yeah, here and there. No company in their right mind would today give you wraparound. What that I mean is when you retire, the company guarantees you they'll provide all the care and all the backup that Medicare doesn't do. First dollar coverage, deductibles and co-insurance, complete drug benefits, maybe even a nursing home, stuff like that. It's just not done anymore. And who knows, by 2020, it'll probably be down to 5%, which is going to cause all kind of pressures, interestingly enough, we can talk about. Nevertheless, let me tell you where I am. I'm a radical moderate. I scream a lot. I believe we need changes, but I'm nervous, as you can hear, about really radical changes, and I really don't think America is really ready for radical changes. That's why I said it to the Clintons in '92, and fortunately, I think at least the Democrats are listening to me a little more this time, and I don't care whether it's Edwards or Obama or Hillary Clinton's latest one, they're all quite similar. They're all building on the employer-based system. They're all trying to make improvements in it, and there are problems with it. Don't get me wrong, I can get going on those problems. The idea that someone has a pre-existing condition in some states can't get coverage, the idea that for a young person, I just don't want to get going. There are problems that need to be dealt with, and all of the major candidates, I'm not here to push one versus the other, of those three have a good plan. And the truth is that most employers acknowledge that the employer-based system is important, although you're getting more and more pressure from these corporations that says, let somebody take this off our backs. So I was testifying a couple of months ago before the Senate Finance Committee, and Senator Barker says to me, now, Dr. Altman, he says, a lot of employers come to me and tell me that they want somebody else to provide health insurance, namely the government. I said, Senator, do they also support a huge tax increase to pay for it? He said, they don't mention that. Enough said. So, what's generating this big growth in spending? People say, well, we're aging. Did you ever watch a glacier, disintegrate? Now, they're doing it a little faster than I used to do it. It's a slow process. The truth of the matter is, aging, at least over time, has a very small impact on spending. Yeah, if you sort of project from here to 2050, it will have a big impact, but year to year, very small. A couple of years ago, we at Brandeis did an estimate between 2000 and 2012, and aging only accounted for about 10% of it. Much more the fact that overall medical inflation, the idea that we're using, we as patients want more things. New hips, new knees, new hearts. Next, I'm thinking that maybe a year from now, I'm going to totally replace myself and come back about 6'2". If you, a medicine could do that for you. Why come out with the old hip? So aging isn't the issue. It's really us. And if you look at the growth, 10 years ago when I used to give speeches and others around the country, we were talking about anybody who went into the hospital industry was into an industry that was in decline. Maybe, middle 1990s. There were predictions that the hospital would just be an ICU and maybe a maternity ward, although women were allowed 2 hours in the hospital to give birth, and then they had to get out. So they might as well do it in the field and not even go back to that's HMO movements. But so it was an ICU and an emergency room, and that was it. There was even rumors that in California they were doing open heart surgery at home. I don't know if that's true. Anyway, I'm here to tell you that's all stopped. Messy. You don't want to do open heart surgery. The blood gets on the floor. It's just not a good thing to do. So the biggest growth is in hospitals. Physicians are and prescription drugs, which is the big bad of 10 years ago is growing much less rapidly. Look at the gap in between 2001, that gray line, and the orange in terms of prescription drugs. It's hospitals, and hospitals are the core of our healthcare system. That's us. And not only that, if you look at hospitals, I'm going to do a fully fast-forward thing. I'm just going to show you. This is total spending on hospitals back in 1994. Watch it. 1995. Look at utilization. Utilization went down 2 years in a row. Then 3 years in a row. Then it's still going down. Then a little up. Then a little more. Then a little more. Then a little more. Then a little more. So these are the years. Oh, I should point out. I'm on the board of a hospital. When this hit, CEO of the hospital came in, said, didn't look good. I said, Ellen, what's wrong? Bad flu season. Not enough patients. Strange industry. But fortunately, flu came back, utilization up. Everyone's smiling. But look at the growth rate. This is America. Now, hospitals are doing quite well, thank you. Look at it. These are the margins of hospitals through 2006. We've had a little drop in total margins because the stock market was hurt. But if you look at operating margins, and some hospitals are 8 and 10% margins. Now, I don't know what's going on here, but most are doing quite well. What about the future? Well, people are getting worried. So if you look at Standard & Poor's in terms of healthcare ratings, if you look at 2005, the ups in blue were much higher than the reds. 2006, they're close. In 2007, you might actually begin to see more. People are getting nervous. Why are they getting nervous? Because government's getting nervous, and I'm going to show you why in a minute in terms of what the government's going to pay hospitals, and also managed care, or whatever we call it, today, is really beginning to cut down. So here's the question that you can all think about, and that's what I say to people. We got 3 choices if we do away with employer-based insurance, and we will do away with it if these costs continue to grow. You got 3 choices. Individual choice insurance, no government subsidy. People are on their own. Individual choice insurance with a government subsidy, and we begin to see what it looks like in Massachusetts, which we did pass recently a law. It says if you're under 300% of poverty, you get a sliding scale subsidy, but above 300%, you get nothing. Now, 300% sounds like a huge number, and it could be $60,000, $70,000. But with health insurance, $12,000 for a family, $13,000, that is not. If you're a 35-year-old and you have 2 kids and I got a mortgage and you got a couple of car payments and stuff like that, and somebody says, oh, by the way, you have to buy health insurance and it costs you $12,000, and we're not going to help you at all. And that's what our state is going to ask them to do. We'll see what happens. It's a tough issue. But at least we're helping out. Some aren't. So the options are 1, 2, or do you believe government-provided insurance is going to be the takeover? Now, I don't know what your bet is, but my bet is number 3. That the people who want a government-run system really, at the end of the day, will win. And I listen, I mean, if that's the end of the day, fine. But let me just, what I do, and for what it's worth, I warn the people who run healthcare systems this number. And I would warn you, too. We tend to think, well, we'll do away with insurance companies, there's all those profits and stuff like that, and we'll all be fine. We'll be able to spend as much money as we're spending for health care, and we'll just get rid of it. Not true. Oh, yeah, you can save a lot on administrative costs. I'm not there. But at the end of the day, you see that purple? That's the extra money that private insurance kicks in for the shortfalls in Medicare, Medicaid, the uninsured. And if that purple goes away, we're going to have a different healthcare delivery system. Maybe we'll be more efficient. Look at this number. With no changes in Medicare and Medicaid at all in terms of the coverage, just the aging of our population, the government is going to be in charge of 66% of all spending for hospital care by the year 2025. So government, even with no changes, is going to be dominating that thing. And if you play out some interesting numbers, I don't have a lot of time to talk about, there's something called payment to cost ratios, which is how much each part of the system pays hospitals versus how much it costs them. And you notice the green, that's private insurance. The red is Medicare and the yellow is Medicaid. And you see the two of them, the two government, are below 100%, which means they pay less than the cost. And the privates pay more than the cost. In order to get, with the change in those demographics, private insurance is going to have to pay like 65% more than it costs them. They're not going to do that. So hospitals themselves, this is the reason why people are nervous. You know, while things are great today in hospitals, things are not going to stay great. And so we're going to have some interesting, we can talk more about that at some other. Now, at the end of the day, indirectly and directly, technology is the major driver, both of good things for healthcare and also costs. And I say good things because a lot of technologies are fantastic. I mean, you know, when I think about the healthcare delivery system of today versus the healthcare system of 30 years ago, 40 years ago, it's incredible what we've done, what we can do. You know, people who used to be in the hospital for 3-4 weeks with open heart surgery is now 3 or 4 days. Things that could never be done. My father died at 65, 66 years old, heart. My father-in-law, they're kept alive. People are, you know, we do great things. But we also do a lot more. As I said, it's not that we don't do things that even that are efficient on the margin, but we use them a lot more because it's a lot easier. You know, as I said, hips are a lot easier to replace, and elbows and knees and MRIs. How many of you have had an MRI? Look at this. I asked my undergraduate, well, you don't count, but I asked my undergraduate class, you know, 17, 18 years, more than 50% of MRIs. What the hell are they doing? That used to be our last line of defense. $1,000 a shot. Your pinky doesn't hurt. You know, you got a thumb, you know, that you banged. And you say you want to go to the doctor, see if it's broken. They say, well, take an MRI. They can look at it. You know, it's sticking out. But so, what is this technology business? Well, technology is wonderful, but not every technology is needed. Not every technology is useful. And so there's been a growing, this is the economist in me said, okay, let's look at that green line, you know, economic, as you begin to add more inputs, more services, you know, you gain more and more value. But at some point you reach the top of the line and you reach this maximum impact. In other words, if you, up to that point, at least you're getting value by adding more services, more physician visits, more hospital days, and so on and so forth. And most, no, not most, all health professionals are trained to do that. Supposed to continue to provide care until it, you know, isn't helpful anymore. You hope that's where they're going to stop. Now, unfortunately, healthcare costs money, and that's the green line. So for those of you who studied economics, we economists like to believe that really you ought to look at the costs and the benefits, and you ought to go to the point of what we call economic optimum, which means you should stop even though there's some value left in adding more because the cost of the service really exceeds the benefit. But as I said, you know, in this country, I didn't say it, it is illegal for the government to, agencies, the FDA, the NIH, the CMS, the Medicare and Medicaid, to take costs into account when they decide on what services to make available. They can take safety and effectiveness, but they can't take costs. We are now the only country that ignores that. Now, we don't completely ignore it, but we have no real clear mechanisms for doing that. And so you wind up with some strange things happening. And what's making worse is there's growing evidence that we've gone beyond maximum output. We've actually reached the area of harmful care. And there's great work that's been done over the last 20 years up at Dartmouth, looking at this from Jack Wenberg and his group. And they've looked at every community. Now, you know, I'm from Boston, you know, we're so arrogant, you know, we believe healthcare is, you know, the center of the universe in Boston. Even we have problems, which comes as a big surprise. But no community is without this harmful care. So the question is, can we begin to get, and as I said, they said lower quality, worse access, and no satisfaction by doing more, and actually you risk death. And of course, Medicare. So, where are we going? Well, I'm just going to show you this very fast. This is Medicare spending as this is Social Security spending as a percentage of GDP, which is the right way to look at it, not just taxes. This is Medicare, including the little dash part, and then we got to push in Medicaid. We are going to be spending one hell of a lot of money come 2030 as a percentage of our GDP. It is there, and it's going to be a problem. And our trust fund is scheduled to go bankrupt sometime in 2019, whatever that means, given the fact that there's no trust fund really to begin with. Comes a big shock to people to realize that if they open their little thing and think there's a little, you know, all the money that you've been putting into your Medicare is all stuck there. But there is a piece of paper. It says government, IOU, Medicare. Well, you know what? They can say, forget it. That's why, for those of you who are faculty members, particularly those of you like me that are getting closer in age, you should do what I do. I give every one of my students an incomplete. And I want to see how they vote on future Medicare increases. It's true. Students look at me like, oh my God. Anyway, this thing's scheduled to go broke in 2000. So can we slow this thing down? Can we get our system out of irons? That's the question. And I don't know. I think what we're talking about, and I don't have time, is really minor stuff. When you listen to the politics, we don't have the political will today to really do anything that's really going to really slow this down. We talk about prevention, very nice, not going to really have serious. We talk about pay for performance. We talk about, it isn't going to slow it down because really, to really do it, we would have to do something quite serious, like other countries. Put in tight certificate of need, limit services, put restrictions on providers, put payments, global budgets. And if you go back to that first slide, the reason why it's not in the Bible, it's political, it's very difficult to do what needs to be done if you believe we want to slow it down. Now you might say, you know, I'll wait for the problem. And that's what I think we're going to do. So, unfortunately, the story is, like my sailing, I kept getting into irons. I think we're flapping around in the wind. And I think it's dangerous. Now, my own view is I wouldn't try to stop the growth. I don't think Americans want to stop the growth. But I think we need to slow it down closer to the growth in our GDP, maybe even a little higher. But 2.5% higher is too dangerous. So am I cautiously optimistic? Maybe. We're beginning to, but you know, I've been hurt a lot of times before in terms of not slowing it down. But at the end of the day, you know, it really didn't hurt us. The question is, can we count on it? That's why, again, let me end with, I think this, I didn't plan on it, but this General Motors strike, both of them are now convinced, the unions and the manufacturing, that you know, this is the time to dig in. The company's saying, we've had it. Unions are saying, this was promised to us. I think it's a tough fight, and I think it's very symptomatic of where we're going. So for those of you who are going to be lawyers, you're going to have a field day. This is a money machine. You know, keep studying on the math. You know, health, all that other stuff is just, you know, property, casualty, just nonsense. Stick in law. With that, I'll stop. Comments, questions?
Yeah, we have a few minutes for questions. He's got to catch a car to the airport in 7 minutes. So
yes, ma'am.
Can you tell us, just in a nutshell, less than 7 minutes, what reforms Obama is proposing?
Well, basically, like, I mean, they're very similar. They would build on the employer-based system. They would mandate that employers that have to provide it, and if they don't, they will have to pay a penalty. They offer a whole new structure of places where people, particularly individuals and small businesses, can go, similar to what we call the Federal Employees Health Benefit, where, you know, you have like a bazaar or, you know, of options there, and where you can see in one place all the different insurance companies. They're not allowed to do pre-admission limitations. They have to have common premiums. In the case of Obama, he would have a what's called a high-cost reinsurance system, which would take off the cost of very sick people from the federal government, from the employer, so that they can lower premiums and have it paid for by the government, and then have manage these high-cost patients to potentially reduce their costs. There's a lot of pieces of it. The key is it does not destroy the employer-based system. It just makes it work a lot better. Edwards has done that. Mrs. Clinton has done that. And Senator Obama has done the same thing. And they have little differences, but those three are clear. And we're going to see a big difference between those three and whoever the Republican nominee. I mean, you can clearly see it. Giuliani and Romney are talking about, markets working better and not government intervention and doing away with mandates. It's going to be a very different structure. We're going to have to decide. Yeah. Yes, sir. Yes, now again.
One of the things that's been never considered in this country seriously is something that is common to health systems in other countries, and that's the R word, rationing.
Yes, I know.
Can you envision a system which there would be without any restraints on access to care?
I think at the end of the day, it depends how we do it. I think we're beginning in the current S-chip legislation that's going to be passed and vetoed by the president. There's a provision to create something called a comparative effectiveness capacity in the federal government, to look at different interventions and see which one works better, and potentially even do cost effective. I think at the end of the day, you could see particularly government plans begin to use that as a way to slow this thing down in terms of the growth rate without sort of taking benefits away. Saying, look, this works better than that one, it's lower, or this has a better cost benefit, let's do that. Whether we'll get to the point of actually restricting services, we could. I mean, I have a whole lecture, and I'm sure Bob does as well, about the options that government has at its disposal. At the end of the day, I don't think we're going to raise taxes enough. I believe at the end of the day we will raise taxes to preserve the Medicare program. But I don't think we're capable of raising taxes enough to completely do everything we're doing today, given the demographics. But I'm a strong believer in the Medicare program, and I think we need to protect it. And to protect it, I think we will need to question some of the services. The negative of that is wealthy people are going to try to figure out ways of avoiding it. There will be some of that. In Canada, they come to the U.S. We'll go to India. But yeah, I do think we will do some of it.
You're indicating that a single-payer system would be very, very expensive, couldn't really be funded by the savings in the insurance profits.
Right.
So how is it that all of the other industrialized countries in the Western world spend less per capita than we do, and they have better outcomes in terms of life expectancy and infant mortality, and they're rated higher, way higher by the World Health Organization? They're spending much less than we are.
You're absolutely right on every front, except for one. We're America. And I tell people the biggest difference between America and the others when it comes to healthcare, in America, healthcare is big business. In other countries, it's a social service. And just because we had a single payer system doesn't mean all the forces that are still at work, unless we start really restructuring, like wiping out malpractice, like taking drug companies and grinding them down, like taking equipment manufacturers, like taking providers and lowering their payments and telling doctors to take a 30% cut in pay, telling hospitals they're going to have to take a 40% cut in revenue. It is not just single payer. Medicare is a single payer, and if you multiply Medicare, while it would cut from where we are, it would still generate a GDP significantly higher. So while I'm look, I'm on Medicare, I think it's a great program. But I don't want anybody else in it. I don't want all these young people in it. We need it. And my fear is that we just can't wake up one morning and redo the whole economic system and legal system of our country. It's just not going to happen. We're not going to do away with malpractice. you know, it's, you know, I'm not stretching on your toes, but, I mean, it's just part of our jurisprudence. So to think that we're going to wake up one day and have the government run it and we're going to look like Sweden, I don't think it's going to happen.
Let's let Dean Heller get to, I'm sorry.
Altman?
Yes.
It's all right.
Let's let Dean Altman get to his plane, and let's thank him very much. And I do have one other thing for you. That we will be glad to mail.
Oh, that's very nice of you. Thank you.
And it comes in this.
Oh, that's even nicer, right? A nice case bag, which I'll take up to New Hampshire with me.
And this is a memento of your serving as the Schroeder Scholar in Residence in 2007.
Thank you very much. It was a pleasure.